On-the-scene coverage of ACC.13 is supported by Janssen Pharmaceuticals, Incorporated.
Welcome back to ACC.13. It is the final day, and it's been an exciting meeting in a great city. And so we get a chance now to talk about the highlights. Athena, looking back, give me some of your highlights.
Well, I thought
besides the restaurants that you ate.
Well, that's what I was going to mention. I thought that the partners trial and some of the results we have there, we've seen an extension then of the new device, the new delivery device,
right.
And I think that was exciting with good outcomes, decreasing some of the known side effects. And then also we've now got the 3-year data which is released. So I thought new devices moving forward.
Thoughts on that?
Yeah, no, I think the 3-year outcomes look really good, and we worry, the new stent would fall apart after, 3 years, and they looked, keeping pace with surgery, just neck and neck, all the outcomes, echo findings, et cetera. So very encouraging.
Very good stuff. Alan, what have been your highlights?
Yeah, I think some of the PE studies have been interesting. They're a little bit probably beneath the radar of a lot of the folks here, where we're thinking about mainstream cardiology topics, but we often get called for PE patients in 2 trials here. One, the PEITHO trial, tenecteplase versus placebo, in over 1,000 patients, and it didn't show any difference in overall net outcomes. There was a bit of a improvement of hemodynamic collapse at a risk of bleeding, not surprising with the thrombolysis trial. But it was in patients with RV impairment and troponin elevations where we often get called to see the patient. And the question is thrombolysis. And I think now you kind of know what the potential benefits are and what the hazards are going to be from this approach. But maybe we're seeing a pivot to more mechanical thrombolysis, kind of like the ACS went from thrombolysis to mechanical revascularization with the ULTIMA study, a ultrasound-based assisted thrombolysis to improve recanalization in submassive PE. So maybe there's a little bit of a pivot from thrombolysis to anticoagulation to assisted thrombolysis mechanically.
Yeah.
Do you think it's going to change?
Intracranial hemorrhage is the worry. That looked pretty bad in the elderly. And the thrombolysis may have a role in younger patients where, if you have a big PE, big, hemodynamic compromise and lower age, so you have to balance the bleeding risk.
And I think they've got some chances in the data with 1,000 patients to give us a little more subgroup information to see where the benefits might lie. Overall, no benefit and to outcomes risk, but figure out who might benefit.
Athena, you were going to jump in.
I don't know that it's going to change what we're doing, except maybe to do less thrombolysis.
I think so. Yeah.
Chris, some highlights from you?
Well, a lot of great trials. Deepak Bhatt presented Champion Phoenix. He and Bob Harrington stuck with Cangrelor, the intravenous short-acting P2Y12 inhibitor. Use it in the cath lab. Looked terrific. Significant outcomes. So that may be something once available that we'd introduce. I think that, for me, the Heart Protection 2 study is a huge study on niacin, the one combined with laripeprant, an anti-flushing agent, and a surprisingly negative finding. Just the slightest hint of benefit, but a bunch of side effects that stood out.
Does that mean niacin's done?
No, it's 2 days old and still giving me indigestion. Okay, that's what HPS2
Maybe it's not going to give you diabetes.
We'll check an A1C.
Quite honestly, to study 2 drugs in a single arm of a trial was told us less than we needed to know. We needed to know in a 2x2 factorial design trial, is niacin effective, is laripeprant inert, and is the combination any different? I think we got data on the combination. That's the sponsor's answer, but the scientific and clinical answers are left unanswered in this trial.
You don't agree with that?
I totally I think this trial has limited information value.
Well, so are you going to still use it? You're going to use it in your practice?
I think it's undefined. I think we know that it achieves lipid goals, but I don't think we know about outcomes, and so it's a hypothesis that remains alive. But I don't think you can put 2 drugs together in a single arm of a trial and try to disentangle them.
So you're saying it's a design problem. Athena, what do you think?
Well, I think it answered the question, does it improve outcomes? And we didn't have a lot of outcome data, so I would think we can use it less. We've got other drugs in our armamentarium to use.
You're going to use niacin laripeprant less. but that didn't even exist on the U.S. market.
Correct.
I think that very honestly, if you're going to study two drugs, you got to disentangle them in a proper clinical trial design.
But I mean, the question comes with niacin, Chris. Do we use niacin now? I mean, is in our practice?
Well, what was really sobering is they calculated there were 30 people who had hospitalizations for adverse events ranging from GI, et cetera, but worsening diabetes, infections, GI bleeds, myopathy, so it piled up.
I'd ask you which drug caused that, though, and I don't think we know. And so, quite honestly, I think where it's going to come down to now is the hypothesis has to be answered. And I think claims data is going to be the place. I think large claims data experiences of niacin and propensity match patients to see what the claims outcomes are. Because no one's going to pay for randomized trials anymore. No. But we got to get some better answers than the trials that deliver.
Interesting. Yeah. So Chris is looking at his iPhone.
Another neat thing was the reminder. Needed a reminder. Reminder was Eplerenone was studied in acute MI without heart failure, so a high-risk patient, but not the heart failure, and showed significant benefits. So I think a decent-sized study. So that is a drug that's working in several areas, and one that we are doing more and more, I think, spironolactone or eplerenone.
You remember. Go ahead.
Do you think we can use spironolactone? Because a lot of people are just switching over and saying they're equivalent, even though it hasn't been tested in that particular group.
The mechanisms are pretty similar.
Right.
And
a little less hyperkalemia maybe with eplerenone. They're both generic. I don't think, it used to be the one was generic, one wasn't, and that was the reason to think about it. But the side effect profile of eplerenone is a little better.
Yeah. You remember when Tony DeMaria sat with us, he was talking about old drugs coming around again, that there was a DIDGE study, isn't that right?
Well, and it was a reanalysis, so it's an old drug and an old trial. And, I think an interesting, really re-raises the hypothesis. I think in part they said, we kind of have forgotten about the rehospitalization benefit seen in the main trial because it didn't change mortality.
Right.
And so I think this simply says, this could be the subject of a new trial with good background therapy that was different than, I think, as you were pointing out, and something to remember. I guess we're supposed to remember eplerenone, but DIDGE is also not a bad drug.
Any other closing thoughts on the meeting, Athena, Alan? Anything? You're looking at me. Are you, Alan? Alan, are you there, Alan?
I'm here.
Alan.
I would take a different tack on the DIDGE trial because I think that they've asked the question about readmissions, but it really was about admissions in that trial in an era where beta blockers weren't used. So I think it creates a hypothesis in an era where readmissions are really important, and it's probably worth doing because the drug has a limited role. But we do need anything we can use in heart failure because it's a costly problem and it's a common problem, and anything we can do to keep people out of the hospital. But I think they're relying on data that's a little too old and out of sync with what we do now.
Yeah, no, this was good for the trialists, and I think then finally,
the publication out of it, but.
The MassCom trial looked at whether you could do elective PCI at community hospitals where the community hospital had a dedicated program, high volume, good operators, et cetera, and the outcomes were excellent. And so that may shift some of, how many patients get transferred to our hospitals. Obviously has to be done in a setting of very careful, program
standards
at the outside hospital, but that may shake things up a little bit.
And where that goes now, I think, is to databases like NCDR.
Absolutely.
To basically now keep an eye on the data and make sure we're not losing grip of the quality as we get out of the trial era environment into the community-based care environment.
Well, do you think the converse should even happen, that you shouldn't be allowed to start it unless you have those high volumes and you're following the guidelines?
Absolutely.
So if you have operators that are under that number, you probably shouldn't be starting it.
No, that's great. Well, you all have done a great job with the panel, as always. Thank you, Chris, Athena, Alan. Glad to have you here. And this has been a great meeting, a very vibrant meeting. The college has put on a spectacular meeting here at San Francisco. So thanks for joining us at ACC 13.